Okay, everybody, it's 7 o'clock. I know that because I'm in Manhattan. I hear the cheers outside, cheering all of us healthcare workers. So it's a pretty auspicious time for us to start talking about some of the things that we do. Let me encourage everybody to go on to the chat box if you want during the course of this to ask any questions. And obviously, we'll try to respond to those as we're having this discussion. We want to keep this interactive if possible. My name is Dr. John Rundback. I have on the line with me also my partner, Dr. Chaim Herman from American Endovascular and Amputation Prevention, and we practice at the New Jersey Endovascular location. So it's really nice to have Dr. Herman on. He's going to be with us about half of this, and he has some other commitments, and the whole thing will be about half an hour. Just so you know, this is going to be part of an ongoing webinar series. We picked a number of topics. Probably would have been worthwhile to show you the topics we have, but I thought as a first topic, it might be a great opportunity to just talk about chronic limb-threatening ischemia, critical limb ischemia, and what those practices are now and how they might evolve and what they look like and how we develop those practices. So let me sort of jump in. I apologize, I don't have a full screen mode. I'm having some computer issues on my computer, but hopefully everybody can sort of see these slides very clearly. So why is this webinar, and why will a lot of the ensuing conversations be about chronic limb-threatening ischemia or critical limb ischemia? And that's because it's a big problem. And, you know, it's interesting, you know, obviously we're all in the midst of COVID right now, and I hope everyone's safe and healthy. But part of the reason that COVID has taken such a big toll in the United States is that we have an epidemic of obesity and diabetes. And those are vulnerable populations. And I only mention this because, you know, it's those same vulnerable populations that are largely affected by critical limb ischemia, along with obviously patients who have coronary artery disease, smokers in particular, dyslipidemia, this is a real problem. And because of the prevalence of diabetes, metabolic syndrome, chronic kidney disease, there is an epidemic population of critical limb ischemia. And you see the number there, which is to me pretty astounding. 300 to 500 major amputations each day in the United States. And what's really even more important about this is that, you know, even though everyone on this webinar presumably is focused on critical limb ischemia and optimal care for these patients, overall, there is a huge problem with identifying these patients. And it's really largely undervalued. Clinical trials have shown that more than half of the patients who have a major amputation, more than half of those 300 to 500 major amputations each year, never even get a vascular evaluation prior to a major amputation. And yet, there's probably underlying arterial insufficiency as high as 80%. If you go by the American Diabetes Association, it's 30 to 50%, but that's only looking at larger vessels. As we're increasingly identifying smaller targets that have a potential for revascularization that can allow wound healing, in our practice, it's closer to 80%. That means, you know, up to 80% of amputations, you know, can be mitigated in one way or another. Another important thing, which I think goes unrecognized, is, you know, Dr. Herman and I frequently see patients who walk in with a wound. And what's not recognized is that, you know, very rarely are sick feet attached to healthy people. And critical limb ischemia or chronic limb-threatening ischemia is a coronary equivalent. What does that mean? You know, that means that if you have peripheral arterial disease, there's a very high chance that you're going to have occult or progressive coronary artery disease, cerebrovascular disease, heart attack risk, stroke risk. And if you look at this, you know, population, patients with critical limb ischemia, there's up to 60% 5-year cardiovascular mortality in this population. So CLI is a coronary equivalent. So what we often do, even in managing patients who might have ischemic rest pain, certainly patients with claudications, we're optimizing medical therapy, and we need all of you who are participating in this webinar to be partners in that, to make sure that all these patients get moderate to high doses of statins, ACE inhibitors or ARBs, antiplatelet therapies, or increasingly 10A inhibitors. Recent trial, the Voyager trial, suggests that rivaroxaban may be equally or more beneficial than you know, clopidogrel and aspirin. And of course, smoking cessation, increasing activity, controlling diabetes, and you know, mitigating all risk factors. As I mentioned, critical limb ischemia is highly morbid. If you look at the data at 1 year, for patients who have limb-threatening ischemia, it's sort of the rule of fours. Only 1 in 4 people will be alive and healed and walking. 1 in 4 people will have ongoing ischemia. 1 in 4 people will be dead, and 1 in 4 people have an amputation, at 1 year. So, this is really a serious problem. It's a highly morbid condition. If you look at the 5 years, like I said, 50 to 60% mortality in this population. And what I think we want to focus on today in terms of thinking about CLI practice is that working together, amputation is preventable. But what does kind of working together look like? This is sort of where we all sort of need to get involved. So, these are a couple of studies, and there's some additional studies out of Italy, where they've done a very good job, in Japan, where they've already done a very good job. In many respects, they've done a better job than we have here in the United States, showing that with higher intensity of vascular care, there's an inverse ratio, inverse relationship to the rate of amputation. In other words, if we all work together in the early identification of patients who have peripheral arterial disease, in the early identification of diabetics or neuropathy to screen for arterial disease, not for the purpose of intervening with a revascularization, but for optimizing medical therapy. For routine foot checks in diabetics and patients who have chronic kidney disease, particularly during the course of dialysis, finding wounds, and if they don't heal after a week or two, referring them for vascular testing and evaluation, and if necessary, revascularization. Controlling all the risk factors. If we all do this, you can see how what happens is as you get more and more aggressive medical therapy, then the rate of amputations goes down. And this just sort of shows, by the way, that more and more aggressive therapy, interestingly now, is more and more aggressive revascularization with endovascular therapy. And I think that's important because part of the resistance, perhaps, to referring patients to revascularization is this idea that this would result in a large incision from the leg, a distal bypass, creating new wounds, anesthetic risk, and the morbidity associated with that. But we now have increasingly advanced and sophisticated endovascular tools and strategies that allow us, in many cases, to successfully restore flow and allow wound healing and relief of rest pain. I was joking around in our preparation for this with Dr. Herman, who's my partner. The things that he does are absolutely remarkable. I think that's true of all of our practice, and those people who really commit themselves to a dedicated, CLI practice, which is important because I think that in terms of practice development, we kind of talk about this, sort of idea of starting from the bottom up, and I'll get to that. But, you need to be prepared to tackle those cases which are the most complex, where patients have been told they have no option disease, no ability for revascularization, or that nothing can be done. And in those cases, our experience suggests that, often things can be done. And all endovascular revascularization is not equal. So we need a very, very diverse workforce out there treating patients with PAD. And we are not specialty specific. We're actually specialty agnostic. And we embrace, obviously, vascular surgeons do most of this work around the country, and cardiologists, and we're interventional radiologists. The point is that we need everybody working together to provide, vascular identification, vascular screening, and vascular care. But not everybody needs to be able to do the most complex critical limb ischemia interventions. I mean, obviously, it's great, as many people as can, but what I think about of this is in terms of coronary artery disease. Obviously, cardiologists are the only specialty that essentially do coronary revascularization, but not every cardiologist will do left main disease, right? Or these cases that are perhaps more challenging. And we like to think that in terms of practice development, we in our practice, and we need others in their practice, need to start becoming the experts in treating the most complex patterns of disease. The left main disease, which in CLI world means complex distal tibial targets, metatarsal arteries, plantar pedal loops, rendezvous procedures, deep venous arterialization, and biological therapies. So, these tools, these strategies really make a big difference. And you can see here that, what we used to do was treat inflow disease, treat the target of opportunity. The perineal artery is open beyond the blockage, so you do a bypass or open up to the perineal artery with a balloon or a stent. But the wound may not be supplied to the perineal artery. There's 6 angiosomes in the foot. That is, the 3 tibial arteries supply 6 different regions of the foot. So we've learned that you kind of have to identify an angiosome. You need to treat the artery that, at least goes to the region of the foot. But we've actually extended beyond that. And you see this concept of angiographically mediated or angiographosome. And we're proud of that term. It's something we've developed and we've propagated. And we've actually found that as you get down into the foot, you have compartmental regional ischemia. So the perfect example is, somebody will see a patient and they have a bounding, palpable dorsalis pedis pulse on the top of the foot. And yet they have a plantar hallux foot wound. And you say, well, there's no PAD, right? But the truth is that there's compartmentalized flow in the foot. And increasingly, we're interrogating each of the tibial arteries independently in several different angiographic projections to try to identify what is the wound supply and targeting that. And this angiographically mediated or angiographosome can make all the difference between success and failure. And we have series of what we call toeplasties now, which are treating just digital arteries, which seem to be the wound supply. I actually did one just today, which may be different than the angiosome because there's tremendous variability in real life patients with critical limb ischemia, particularly diabetics who don't form normal collateral pathways. So what you might anticipate from the angiosome concept to be the wound supply, very often, I'd say as often as 60%, Dr. Herman, is not actually the wound supply when you interrogate things.
Yeah. One of the things that I've always been thinking about when people are talking about this in terms of the angiosome is, one vessel is great, 2 is even better, and 3 is really really good. So we're absolutely always trying to get to this angiographosome. As that's going to be a term that you're going to talk about in probably about 30 seconds from now. But one thing that I just wanted to add on to this before I do have to leave in a couple minutes is just the passion that I think that we have for treating this disease that I think is really needed in order to try to get these results, and that's why all endo revascularization is not equal.
Right. And increasingly, we have other therapies. We've been part of this Pluristem clinical trial. Interesting, just did a Pluristem injection in a COVID patient because these are mesenchymal cells, which really can have tremendous modulation of a whole host of biological responses. For COVID patients, it modulates immune response. But in PAD patients, we found to be very useful in non-reconstructive cases to help promote angiogenesis wound healing. And time will tell, but it's been very, very appealing. Deep venous arterialization, when done in the right way, as a downstream target, also been a very effective therapy whereby we convert the blood returning veins into blood oxygen carrying arteries down to the wound base. And again, I think that's where this sort of comes in, that, we talk about the idea of non-reconstructible disease. And before I go on, let me say, please, I know there's a chat box, so please, if you have any questions or comments, if you bring them up there, we'd love to be able to address each of those things. So we talk about the idea of non-reconstructible disease, but that's really a moving target. If you think about it, it's a moving target in all of medicine. All of our goals in medicine is that each year we should have better skills, strategies, and tools to treat disease than we could the prior year. And PAD and critical limb ischemia therapies, particularly endovascular therapies, are advancing very quickly. We've had the good fortune to be participant in a number of clinical trials. We still are. For instance, we'll be evaluating bioabsorbable and dedicated below knee stents, which never before existed. It just was approved, the first scaffold for tears in the arteries below the knee when we repair them. So this is really moving very, very quickly, and we have the opportunity to get access to these technologies earlier. But the trick is that when you're told that nothing can be done, that may not be entirely true for those individuals who have a committed CLI practice. And this sort of shows some of those sort of things. Certainly novel emerging therapies, the stem cells I mentioned, the deep venous arterialization on the left, and even bypass surgical practices, can do some very amazing distal bypasses now and limit amputation to minor amputations. And I have surgical colleagues who are extraordinarily skilled at doing these sort of things. And I think, the question always comes up, what's better, endo or surgical? Obviously, each one has advantages and disadvantages. But I think at the end of the day, by somebody who's highly committed, and as Dr. Herman says, passionate, whatever you do best, Ours is an endovascular practice, and obviously avoids the need for incisions and anesthesia. But, you know, other people who do surgical bypass get spectacular results. And it's just a matter of
But
being, you know,
if
focused.
I may interrupt for 1 second on that, I've seen, I follow Twitter a lot and talk to a lot of vascular surgeons, and sometimes they'll post these nice bypass cases that they perform. But my first question to them is, did you try endo first? And JR, what do you say? A large percentage will have tried endo first, maybe not have succeeded, and then go to bypass. Um, when maybe trying a little bit harder for endo first could have worked better.
Yeah, we'd like to bend that curve, right? We'd like to see
So,
increasing skill set, tool set, dedication to getting endovascular success first before you compromise veins and expose patients to an operation. But, not in all cases. I think my point is that, in being specialty agnostic, we recognize that everyone brings their own skill set, and that's
mhm.
really valuable and important. And it's really, I would say, it's not a question of endovascular surgery. It's endovascular and surgery. Everything has its role.
Yeah.
But clearly the endovascular skills that we've developed, continue to develop, I think are sort of moving the bar in what we can accomplish. Uh, this is an interesting slide that sort of supports this idea of treating patients who are considered untreatable, no option or non-reconstructible. This is on the Liberty trial. This is a registry conducted by Cardiovascular Systems, so shout out to them. I do have a relationship with Cardiovascular Systems and a lot of companies, but that's not why I show this. What this shows is that if you look at patients who are RC6, so that's Rutherford class 6. So Rutherford class 6 are typically no option patients. These are patients who have gangrene proximal transmetatarsal joint, maybe heel gangrene, larger and extensive wounds, who traditionally would be considered patients who need below knee amputation. And yet, if we look at the 6-month freedom from major adverse events, both in terms of death, major amputation, and target vessel revascularization in that Rutherford category 6, that green box, while they're not quite as favorable as patients in our Rutherford class 2 or 3 or Rutherford class 4, look at that. This is really, really salutary effects right there. I mean, clearly they have a higher mortality because they have underlying coronary artery disease. But major amputation, avoidance of major amputation in 87% of cases, avoidance of target vessel revascularization, 85. So, look, not every Rutherford 6 is the same, but I think this speaks to the fact that even the most complex patients can be amenable to endovascular therapy and avoid major amputation, which is really actually an unanticipated and very important take-home message from the Liberty registry. So again, thank you to CSI. So with that background, maybe we can talk about what practice development models work. So I don't know entirely, who's sort of listening to the webinar, but, I imagine there are some people who send patients and some people who treat patients medically and some people treat patients surgically. And we probably have the whole range, but, certainly for those who, identify patients and treat them, we embrace this toe and flow model. So, people have talked about CLI teams. And the CLI team would be sort of like the, pit crew at a, racing car event, where everybody sort of, approaches the vehicle at one time and all things are addressed at once. Thank you, Dr. Herman. But we prefer this idea of toe and flow, where the main focus is on the toe, which is really the foot, which is wound care, identification, ongoing observation, longitudinal involvement, and then flow, which is where we and the other vascular specialists come aboard to really, in a very targeted and specific way, restore blood flow down to the wound. And this is sort of an ongoing sort of process. It's not a single event. As those of you doing the wound care know, these patients need to be seen on a regular basis. And those of you doing revascularization know that at least 1 in 4 cases, 40% in the Olive registry from Japan, additional revascularization is warranted. So we have to anticipate that up front, tell patients that this is going to be an ongoing process to save their limb, that there's very likely they'll need additional revascularization of either other vascular targets or vascular targets that close after initial therapy, and repeated, interventions, in terms of wound care, minor amputations if need be, debridement of tissue, medical therapies. The other thing is this whole idea of bottom up, which I've already kind of alluded to, and that is we need to be committed to treating the most complex patterns of PAD. And for those of you who are want to do the vascular aspect, I think that you need to change your focus from saying we're only going to treat proximal disease, and if it's distal disease, there's nothing we can do, to building a practice from the bottom up. That is, send us you're tired, you're poor, you're hopeless, you're hungry, you're broke down, you're failures. I kind of use that, that's why we had a Statue of Liberty on that earlier slide. That's from Emma Watson, my own modification. But, I think you have to be committed to treating those most complex patterns of disease and, giving it a shot. Going to educational seminars so you can treat complex tibial disease, learn how to do the pedal access, learn how to do rendezvous procedures and pedal arch reconstruction, learn how to do DVA and other things like that, transcollateral revascularization. Because if you commit to treating the most complex patterns of PAD, you're only going to get better. You had a conversation which actually was a little embarrassing with some colleagues of mine at one major meeting. We were talking about plantar pedal loop reconstruction. And somebody said, how often are you successful? I said, about 3/4 of the time. They all looked at me like that's crazy. And, we all have a tendency to talk about our successes and overlook our failures. But they said, come on, that you're anatomically, you can only do that about maybe 1/4 of the time. I thought about that because I didn't want to be one of those individuals who says things that may not be true. And what I realized is that I think they were right and we're right. When we first started doing these complex interventions, probably 1 in 4 times we could work our way through the plantar pedal arch using multiple projections. And I think now 3/4 of the time we can at least partially revascularize out to an important wound vessel. And this has just been a matter of developing strategies, tools, and techniques and commitment to this over time. So I think that as far as the practice development, you need to commit to these things early on. Obviously, your skill set, your outcomes may not be as good as later on, but these patients are otherwise facing invariable amputation. And part of this bottom up is be willing to sort of take on salvage cases, other people's failures. As you saw from that Liberty data, there's tremendous opportunity in treating patients who have been told that they have no alternative but amputation. I think that this is something we need to do. From a more logistical point of view, how do you sort of get access to these patients? So there are a couple of things here that you sort of see that I have in yellow there. So first of all, our experience has been that every podiatrist and every skilled nursing facility that you see, they're enriched for these patients, but each one results in referral of 1 to 2 revascularization cases a month if you're being judicious and appropriate. Again, we're not suggesting revascularization for patients without wounds or without pain, but we want to really make sure that we're doing the most appropriate therapy in the patients most in need and highest risk of otherwise limb loss. So it's important to build the skilled nursing facility. Now, I could do a whole webinar on how to do that. We've gone through various models, first by just calling the directors of nursing saying, hey, we're out there, send us your patients, through to participating in wound rounds. But I think the best model is to have extenders who have privileges and see these patients there. And now we're working with companies where these extenders are part of a company that provides the vascular consultations. It tends to get overlooked. Wound care and skilled nursing facilities is an ongoing thing and very resource dependent, and really can markedly affect many things within the nursing homes. First of all, it's a strain on the system. The care is a strain. The optics to the family members is not very good. And there have been several cases of limb loss in facility, which of course, has its own exposure. So we found the best model is to have people who go into those nursing homes, have contractual relationships with those nursing homes. We're allowed to see those patients. So we can work with the wound teams there in a very effective way of communication to get access to these patients and treat them again as appropriate. And you see that it says build reputation because that's important. You can't be, just treating indiscriminately. You got to make sure that everything you do is well-founded and well thought out, well communicated. And then of course, over time, the results to support them. We found you can work in other people's centers or you can set up your own centers, but no matter how you do it, whether you're working in other people's centers or other hospitals, working under, hospital agreements, the goal is by being completely committed to critical limb ischemia, you want to be the known vascular provider for this disease state. And of course that takes time. Some of that is, getting out and giving talks and, meeting the doctors. I mean, It's a little bit like politics. You have to go and shake a lot of hands and talk to a lot of people. But if you do that, it doesn't matter whether you're on the, the wound care side of it or the revascularization side of it, you still want to be known as the provider for these patients. These are complex patients who need frequent and attentive care. And it's really important if you step up. You'd be surprised, particularly the primary care, particularly people who wound care. The primary cares are looking for somebody to help with these patients, because they're very complex patients, which again require a lot of resources and a lot of attention. And if they can, if you will, offload, to pardon the pun, those patients to wound care providers, that's extraordinarily valuable. And that's been the premise of the success of wound care centers. Certainly, if you have the wherewithal, you can own your own center. We've collaborated with American Endovascular, and some of you who may want to do this can reach out. You'll see some contacts at the end to do this. We've also worked with hospitals. We prefer the medical service agreement versus an employed model. And we found that allows us to best practice our trade without worrying about having to hit some productivity models. In the end, I think it's all about diversifying so that you can be the vascular provider at any number of places. The goal is, you may think that the patients will come to you, but the truth is, even though this is a very, very, a prevalent population, you need to go out and find those patients. And in doing so, build your reputation to continue to be able to find those patients some more. So what are our goals? So, certainly, I think we've talked about this. Encourage early imaging to triage patients, identify patients. I like Dr. Herman's idea. Anyone with gauze on the leg should see a vascular specialist who's committed to chronic threatening ischemia. If you don't have a wound that hasn't healed after 1 to 2 weeks, it has to be taken care of. You need to be available to respond and see patients within, a couple of days. Maybe on a Friday, you'll see them on a Monday, but these are not patients who can wait. During this COVID crisis, we've had 2 patients who had delayed therapy, one by us, and one they were just afraid to come in, who ended up with gas gangrene and major amputation. Don't accept other people's failures. We've talked about that. There are options that everyone on this call can work together to develop to provide optimal care, recognizing this may require repeated attempts or repeated interventions, repeated debridement, aggressive wound care, both, during the short term of the patient's acute wound, as well as in the long term when they're likely to have recurrent disease, because these patients have the same underlying risk factors in the long term that cause their problems in the short term. So we've done actually pretty good on time here. I didn't see too many questions, and there's still a little bit of time if people want to sort of join the chat and ask some questions. But certainly, look, we're just one practice, American Endovascular and Amputation Prevention. You can see this is currently the sites at which we work. I think part of these webinars is not so much about what we do, but try to raise awareness, increase the standard, if you will, for identifying and treating patients with chronic limb-threatening ischemia, recognize the severity of this problem, and most importantly, recognize the options that exist so that we can all do better. Collectively, I do believe working together from early identification through to great wound care, appropriate utilization of specialists. We didn't get into a lot of this, not just ID, but physical therapy and rehabilitation, nutritionists for good dietary management, and the whole range of care through to revascularization, long-term assessment, and repeated care as necessary. I think that collectively we can make a difference. And as Dr. Herman said, I'm passionate about it, he is, and I think that anyone who's on this webinar probably is passionate about it as well, and that's why you've participated today. So this is just the first of an ongoing series of webinars. We're going to get into some other topics, more specific topics down the line related to wound care, related to some revascularization strategies, certainly patient care strategies, medical therapies. Tell you the truth, I don't remember the entire roster agenda offhand, but we're going to try to be fairly comprehensive during the course of this. And we hope that those of you who tuned in today will again tune in for each of these additional topics, and perhaps advise your colleagues who did not tune in that this might be something that's useful for them, so they can participate next Tuesday and following Tuesdays. I know we're doing 4 Tuesdays in a row for a month to start, so we can grow this. We need to communicate and collectively communicate better. So I do see one question, which I have a minute to answer. Are there endovascular techniques that you avoid doing at the outpatient center? So that's a good question. And the answer is generally no. The reason to do things in the hospital would be if they have substantial comorbidities, or the rare patient who needs anesthesia. I mean, we use moderate sedation, but we found we do the most complex procedures. Now, we have developed some strategies, and this will come up in future webinars, to avoid complications. In this latest OBL, we've done over 400 patients and only had 2 patients go to the hospital, both of whom were sent home very quickly. So there are techniques that we utilize, but there are not patients that we will generally turn away. We'll even do distal deep venous arterialization in the outpatient center. We find that actually patients like this center so much better. The efficiencies are extraordinarily high. We have the tool set that we need. We have dedicated staff and resources. So to answer that question, we don't avoid anything outpatient center unless there's other mitigating reasons, comorbidities, need for anesthesia, patients who just won't stay still no matter what, and possibly insurance. So, yeah. Anybody else have any questions? All right, well, let me thank everybody who participated. This has hopefully been great. I've really enjoyed doing this. I appreciate I'm honored to have had you spend some time with us today. We will meet again next Tuesday. All right, stay safe, everybody. Stay healthy. God bless.